Good morning. You're listening to Insurance Matchmaking, your path to health, life, and Medicare coverage with Matt Libby Insurance. And now, sharing his knowledge, here's your host, Matt Libby.
Well, welcome back to Insurance Matchmaking. As I used to say, great news. You don't have to listen to just me today. In fact, not just one guest, but I have two. I have Clint and Stacey from Family Wellness Pharmacy. I meant to ask her, give me one of your cards so I do the introduction right. But we both are actually advertisers in the local magazine. You may be getting them in your mailbox, the Cookeville
Neighbors.
And I was like, well, I need to have a pharmacist on my show, so I reached out and said, hey, come on and join me here. So they're here this morning. One thing I wanted to just kind of reminder, I thought of it this morning because I actually did mine, is if you have a Medicare Advantage plan and you have over-the-counter benefits, June is the last month of the quarter, and I think Tuesday is July 1st. So if you haven't placed your over-the-counter order this quarter, you need to get that done before Tuesday. And before Tuesday, you got to do it by Monday. So this is Saturday, so you'll know you have a little bit of time if you haven't done that yet. If you need help on that, give me a call at the office. I can help you. You don't have to be my client. I can still help you figure out how to get your over-the-counter benefit, because that's something you signed up for. Let's make sure you're getting it. So anyway, I guess it's like talk to Stacey first of all. Let Stacey in, and she can turn things over to Clint. But tell me a little bit of history. How you got into pharmacy, or how you decided to launch your own pharmacy. And
oh gosh,
did I stump you?
Well, my dad is a pharmacist, so that kind of geared me towards the pharmacy direction.
Gotcha.
I may have swerved a few times and wanted to change what I wanted to do, but ultimately I ended up going the pharmacy route. Worked in retail where I met Clint.
Okay.
Do we want to say how long ago?
Long time ago.
Long time ago. And we worked together there then. And then I went into hospital pharmacy probably for about 10 or 12 years and did that niche, and then kind of needed to shift. So I reached out to Clint, who already had a pharmacy in Livingston.
Okay.
And he gave me the opportunity to work there, and then it just kind of went into eventually owning into the pharmacy. So
do you have more than one location then? Is that, or just
we do?
You do. Okay.
Yep.
I didn't we were talking about it before the show. We probably should have researched or content. We really didn't. But I like the spontaneity when we do this. Is kind of, I'm learning along with the listeners of what makes them unique. What makes Family Wellness Pharmacy different from other pharmacies? Obviously, you're not a chain, so that's different. Do you have? I know like a lot of small town pharmacies usually have kind of like an umbrella organization, like they might be a Rexall or something like that, so they have kind of a national branding. Do you have anything like that, or are you strictly independent?
Well, we have two locations. We have Family Wellness Pharmacy, and then we have Allgood Family Pharmacy. So we also have a location in Allgood.
Oh, okay.
We do have something similar to that. Each one of them is different. We've kind of tried to make it where people have access to whatever they're looking for in that regard. But for the most part, we have really tried hard to keep things local if we can.
Right.
If you come into our pharmacies, you'll see a lot of products that we stock over the counter are locally made products even. And there's a large contingency of people who are making products that benefit people that are from our area.
Right.
But yes, we do have at Family Wellness Pharmacy, for instance, we're a Good Neighbor pharmacy.
Good Neighbor,
so
okay.
we have Good Neighbor products. Yeah, we've got a little bit of everything. As far as independent pharmacies, independent pharmacies stand out from chains in service.
Mm-hmm.
Is where really you're going to see the best improvement. All pharmacies sell the same medicines.
Right.
They all come from the same wholesalers. They're exactly the same. So we stand out and we strive to provide the best pharmacy service that we possibly can.
Right.
And what that means is when you come in, we're gonna greet you with a smile. We're going to ask you how your day's going. We're going to try to fix any problems that you have. We're not going to have you take a ticket and sit down and wait for 20 minutes before somebody looks at you. You know, we're going to take care of you. We're going to help you with fixing any insurance issues that you have, any medication issues that you have. We're gonna collaborate with your doctor, talk to them, fix those things, come up with solutions to problems. And we really work hard. We offer a lot of services that chains don't offer. A lot of compliance packaging. We do at the pharmacies to help people remember to take their medicine.
That was one of the things I was going to ask you. You beat me to it. I have a client who's was a friend of mine before he was my client, and we talked about the insurance angle, that the preferred, the standard and the preferred pharmacies. In one of the things he did was he elected to keep with his pharmacy that was a standard. So some of the costs are a little bit higher because they did the packaging that they just took his prescriptions and gave him the his daily packs, and that's a big service I've found for a lot of folks. I get my prescriptions from Express Scripts, so I have to do it all myself. Now that brings up another question though. My wife was telling me TSA said, and yours is packaged, so it's probably good. They're no longer going to allow you in your carry-on luggage to have your prescriptions in the daily package. They have to be in the bottles with the labels. And supposedly it's a drug trafficking, and I'm like, people who are trafficking drugs aren't doing it in 1 or 2 week pill minders.
Yeah, there's a lot of things that don't make sense with TSA.
So when you do when you do the packaging, like the daily, but is it labeled? Are they labeled with each item that's in there, or just kind of here's Monday morning, here's Tuesday lunch?
It's usually labeled in a monthly form, like a monthly pack or maybe even a weekly pack, but it does have listed each pill that's in there, the strength. Yeah, it's properly labeled with your name and everything.
I'm just curious if that wouldn't be an issue for travel.
Yeah, it's not a typical pill minder that you can buy over the counter, and you just put the pills in there.
Right. I knew
this
that.
One has like she said, it has the patient's name. It has a description of the medication, so you can tell what's what. It has all the medications that are listed in there and everything. So
now, are they sealed kind of like I haven't actually seen how it's packed, like a blister pack, or is it like Ziploc bag kind of thing?
It's a blister pack. You pull back the full when you're ready to use it. You can tear it away. So if you have morning, afternoon, and evening, and you're going to be gone during lunchtime, but you have medicine, you can take just that blister pack and put it in your pocket, and that way you have it with you to remind you whenever you need to take it. So that way you can not miss a dose. And you said that you still get your stuff through Express Scripts. That still doesn't mean that we can't package it for you. So you can always come, bring it in, and we'll be happy to do that. So you're not limited just because you don't get the medications through us. We would still be happy to package them for you.
That's a great point to add. Yeah, I hadn't even thought about that.
We have many veterans that have to get their stuff through the VA, but they need that kind of assistance. So we have a couple of VA or veterans that bring in their medications, and we're able to package those for them as well.
That's a good thought to have. See, you got to plug that. I'm glad we brought that up. Clint, we were talking about the upheaval in the Medicare world. As my listeners know, I generally focus primarily on Medicare. I don't do just Medicare. I do all health insurance. So I started out doing the under 65 ACA stuff, and kind of review a little history. I don't know anything. I don't say this. I don't know that. I don't have any experience in health insurance prior to the Affordable Care Act. That's when I got started. I know I may look like, I've probably been doing this for years, but no, it's get close to about 12 years now that I've been in insurance, and the marketplace stuff had already started. So I didn't deal with doing health insurance prior to the healthcare marketplace. But when it comes to Medicare, we've had a lot of people. I've talked about a lot of the plans not offering us commission. So I can sit here and gripe all day about that, but there's been changes, especially after the Inflation Reduction Act, things like that. Or Stacey, you can answer too, either one. But what has been your view, or what's been some of your struggles with taking care of your patients in the last year or so of the changes that have been affecting Medicare when it comes to the prescription and the Part D world?
When you look at it, there's different views you can take from it. Just over the years, talking to people and trying to help them even pick Part D plans when it comes time to enroll based on their medications. Starting from the pharmacy side, Medicare, it really has gotten difficult from a pharmacy standpoint. The Part D plans are all controlled by PBMs, pharmacy benefit managers, and they're typically not very friendly to the independent pharmacy side.
It's funny about bureaucracies.
Yeah. and mainly that is because most of those PBMs are vertically integrated, where they own insurance companies, they own chain pharmacies.
Right.
And when typically from our side, when a competitor is also the person who's reimbursing you for your services, that you tend to not get reimbursed very well. So right now in pharmacy, there is a major, you could even see it with even some of the chains have took a toll from this. If you look at what's gone on recently with Walgreens, 10, 15 years ago, they were a $10 billion company, and they sold recently for $1 billion.
Yeah.
Or I'm sorry, they were a $100 billion company, and they sold for $10 billion. They sold for 10% of what they were worth 10 years ago. So we are all going through this. Unfortunately, I think that there is going to be there's light at the end of the tunnel. It's either light at the end of the tunnel or it's a train going to hit us, one of the two. I'm pretty sure it's light at the end of the tunnel, and we're going to get through it eventually because, the practices that a lot of the PBMs are doing are hurting patients and pharmacists, independent pharmacies, and people are starting to catch on to that.
Right.
And 15, 20 years ago, none of those companies were in the were on the Forbes list, and now they all are. So we know where the money's going.
Right.
But so that's one side of it. The other side is looking at it. There's getting to be less and less options as well.
Hold that thought. We're actually coming up on the break.
Yep.
And we'll go back into those options as soon as we come back.
Twin Lakes is celebrating their customers big this summer with their 10 gig days of summer. Visit them online at twinlakes.net/summer2025 to register. All entries will be accepted until July 16th, and the grand prize winner will be announced on July 17th. To boost your chances of winning, enter every 24 hours. More entries mean more chances to win big. Stay updated by following them on Facebook, where all the winners will be announced. Don't miss out on the fun. Learn more at twinlakes.net. Got items you no longer need? Give them a new life when you donate them to the Habitat Restore. Give them a new life. Drop off your gently used items and support a great cause. And mark your calendars for the second Saturday of each month for a pop-up donation event at the First National Bank in Sparta every second Saturday of the month. Plus, you can also drop your donations off to the Habitat Restore in Cookeville. Your donations make a difference right here in our community when you support the Upper Cumberland Habitat Restore.
And now, back to Insurance Matchmaking with Matt Libby Insurance.
All right, and we're back. I cut Clint off there just before the break. He was talking about some of the options that are coming into play with some of the changes.
Yeah, I'm sure you've talked about this before as well, but as we look at the Medicare Part D landscape, it's getting slimmer and slimmer every year. There's less options. Mutual of Omaha last year left the market.
Yeah, and so did Farm Bureau.
That's correct. And
I don't usually mention insurance company names, but when it's something like that, they're no longer doing it, I figure I can say it.
and a lot of the plans also slimmed their portfolios down as far as options as well. So there's been a big retraction in the Part D market, and that's really when you have less competition, prices tend to go higher.
Right.
and so that's been a something to deal with. It seems like most of the big insurance companies are tending to really push for their Advantage plans over the Part D plans. So the Part D plans they're getting harder and harder to manage and help people with.
Right. Well, you mentioned the Medicare Advantage plans, and we were talking during the break that I always say on my show, Part D is Part D. I don't care if you have a separate standalone Part D because you have a Medigap plan, or you have Part D with your Medicare Advantage. One of the things I notice a lot this year, and I'm expecting it to probably be even more so this coming year, is the Medicare Advantage plans having a deductible on their Part D. It used to be very rare. This year it was common. This coming year, I'm thinking it's going to be most every plan's going to have it. The drug plans, it's usually if they have a premium, you're paying a little bit more per month just to have the plan, then you usually get some breaks on those deductibles. They're kind of pre-charging the deductible. The other thing that came about from the Inflation Reduction Act, in insurance circles, we were calling it 3P or P3. I can't remember which it was, and then they said no, or CMS I think told us to stop doing that. But the prescription payment plan. Do you have many clients that are taking advantage of that have those Jardiance and Xarelto? As I always say, when we used to have the infamous donut hole, I would say, if you see it advertised on TV, you should expect to hit the donut hole. Now it's if you see it on TV, you might want to take advantage of the 3P.
Yeah, we do have some that are taking advantage of that. There's really been a lot of misinformation or just not enough information about it, I think. And unfortunately, a lot of the insurance companies go and promote it to people who don't really necessarily need it.
Yeah.
And we run into that sometimes where people have signed up for it and they're really not. So it's not designed for them to help them at all.
Yeah.
But we do have some that are. If typically if you're on a branded medication with a high deductible, and you're on a high deductible plan, and that's causing your out-of-pocket expense to be higher at the first of the year, much higher at the first of the year, then the MP3 plan could be a good option for you to kind of spread out that cost. Now that plan does not reduce your cost.
Correct.
It only spreads it out throughout the year to make it more easily to afford. So a lot of misinformation with that coming out, and it kind of just got thrown in all of our laps as pharmacies too.
Yeah.
For us to deal with, and there wasn't much guidance, which typically
and there wasn't and that's one of the things I noticed I kind of cut you off there. In my circles is people were saying, well, I went and talked to local pharmacy, and they don't even know what it is. It's like, but in the communication, there was a lot of confusion from our part and how it was supposed to work, and one of the things from our perspective, if you were already on a plan, you could contact them like in December and say, I want to go on this payment plan next year because I know I'm going to have all these deductibles. But if they were signing up for a new plan, until they got their member materials in the mail that had their card, they had to call customer service. And the problem was some of the people were calling their carriers, and the carriers didn't know what to do, how to do it, because it was so new. So, yeah, there was a lot of – I'm sure we've probably ironed out most of those wrinkles in that regard. The max out-of-pocket's only going up like $100 this year, so it's it's not going to be there's going to be a lot of, I start to say influx, but fluctuation with the Part D plans, I think, in this coming year. Just there's one of the things a lot of the companies, and one of the reasons why they're going, without mentioning company names, that are saying, for the rest of the year, we're not going to pay commission on our plans. And one of the problems that they made was, or self-made problems, was they kept co-pays on those higher tier drugs versus the CMS model was tier 3, 4, and 5 are co-insurance. They're percentages of the cost. The people are still going to reach that $2,000 maximum, and a lot of people are getting credit for getting the $2,000 maximum with not spending anywhere near $2,000. Which, and again, you may not have looked at it from that perspective. I had a client, and I use it. I've done this example on the show. There's a plan out there, and I just kind of round numbers. There's a plan out there for $27, and there's a plan out there for $95. I had a client because he had Jardiance and Xarelto. With that $95 plan, which is what I put him on for that reason,
correctly,
it was going to cost him about $1,600, and then he was going to be credited with having the max out of pocket and didn't have to deal with the deductible. The $27 plan was going to cost him about $2,200. The premium added on to the $2,000 out of pocket. That makes no sense whatsoever. And it was because the plans had to copay, but the CMS model was, well, the copay's $47, but the percentage, it should have cost $75. And so they were getting credit for paying $75 when they were only spending $47. And again, those may not be exact numbers, but to give you kind of the general idea. So that was kind of screwy.
Yeah, well, the reason why they're not paying commissions, this is my opinion, obviously, but the reason that they're not paying commissions is because you did too good of a job. Essentially, I mean, when the brokers are putting people on the right plans, the agents are putting people on the right plans for them based on their medications, just like in that instance you described. Well, that takes some money out of the insurance coffers,
right?
Because they're not getting back as much as what they should because you put them on the right plan, and so they don't want as many people on that plan,
right? And that's part of the thing, and because some of the Medicare Advantage plans, it's the same thing right now. This is maybe not necessarily pharmacy related, but the Inflation Reduction Act influenced all of that with that $2,000 max. Sounds great, but if you take lisinopril and atorvastatin, that $2,000 maximum actually hurt you, which is and it generally is the majority of my clients. The majority of my clients are on a blood pressure, cholesterol, and metformin.
Yeah,
and they're cheap drugs. Thyroid. And basically, those are your four most common. Those people are never going to come close to that $2,000 maximum, but they've lost a lot of other benefits because the insurance companies happen to hedge off that cost of, and that was one thing, and I'm not sure if you know the percentage. The Inflation Reduction Act, one of the things that changed for this year when we went to the maximum out of pocket, once they hit that, what used to be it's still considered a catastrophic phase when we had the 4 stages with the donut hole. The insurance company's now paying 60% of that cost, where it used to be when they hit that catastrophic phase, they were paying like 25. That's a big jump in cost. And when you're talking about a drug that costs the drug might cost $10,000. And that's the thing people don't realize. It's like, yeah, there's drugs out there that cost $10,000. So the people hit their maximum out of pocket the first in January.
Yeah, that's also an issue we see in pharmacy. We'll have patients that'll come in and they'll just bring in the prescription will be sent in for them.
Yeah,
they'll come to pick it up and it'll be $250 copay, and they'll say my insurance not paying anything. Like, actually, they are paying.
They paid a bit
because it's a $3,000 medicine. And it's just that's your portion.
That's your cost share. Yeah,
correct.
And that was one of the things you mentioned, that a lot of times, and you mentioned coordinating with their providers and such. How much of your time do you spend calling a doctor's office and say, hey, you sent in this prescription and you marked no substitutions and the brand name is not on the formulary with their insurance? Will you authorize a substitution for a generic?
Well, Clint can speak to it as well, but I feel like that's gotten a little bit better. I think a majority of the doctor's offices are doing their research on the formularies prior to it. I think it's become such a big impact in their office to do prior authorizations. I feel like PAs or prior authorizations have gone through the roof as far as insurance requiring them on almost every medication. So I think the providers are researching that a lot before they even make it to us so that they kind of know. So it's gotten better, and I think we're able to do a lot of that by faxing and doing a lot of it electronically and stuff. But it's definitely, there is a lot of time spent trying to figure out what's best for the patient, because oftentimes the formulary that have is not what the physician would like them to be on. So they're
Right.
having to make changes and choices.
Right. One of the things I've found kind of surprised me, there's a couple of prescriptions out there that, especially like I've got a client who's maybe coming off a group plan or an ACA plan. They're turning 65. They're going on Medicare. And so they've been taking the generic. And then so then I start shopping their Medicare plans and going, you need to tell your doctor to prescribe the brand name. They accept the brand name. It's going to be a little more expensive, but it's going to cost you a whole lot more to get the generic because it's not on the formulary.
Yeah, and it takes quite a while for that formulary to go through, and we have stuff that we see coming down the pipe that's going to turn into generic, and we're excited for it, but we know that it's way down the road before the patient could ever change it to the generic, because the insurance usually prefer brand over generic.
Now, it's one of the things I haven't really got into. I usually tell the person to, contact their doctor, but do you help them sometimes with the, like, formulary exceptions?
Oh, for sure.
Filing that, or
Yeah.
just kind of, or say, go back to your doctor and say they need to do this, or
No, we that's one of the major things I think that independent pharmacies can and should be doing is helping the patients with that, because there's a lot of harvest out there for that. A lot of times the medication can be changed. In instances where there's brand generics, sometimes I would venture to say even probably a majority of the time, you can even look at it where what is your brand name copay on your insurance versus just paying out of pocket.
I tell clients, I always ask the pharmacist which way it's better, through my insurance or just pay for it.
And it's great to ask, but pharmacists should be identifying those situations and proactively helping the patients with that.
Yeah.
What I like to do is when I see something like that come across where I see a high copay for a brand name and I know there's a generic available, I go look up and see what the cost of the generic is. Yeah. And then we'll put a note, or we'll have a flag that when the patient comes in, let's talk to them about, hey, would you want to do this? Because it could be cheaper. It could save you this much amount of money if we did this. Anything that we can help with, if the insurance will allow us to. A lot of times they don't allow us to because they want to put the burden on the doctors, so they won't let pharmacies do certain things. Right. But we try
Hold
to do
that thought, because we're running out of time, and I do want to continue that conversation. We are going to continue and tune in next week. We're going to talk some more on this. I'm not letting them out of the studio, but what's the best way for people to find your pharmacies, find you guys?
You can find us on social media, on Facebook or Instagram, or you can call us, Allgood Family Pharmacy at 931-537-6337, or at Family Wellness Pharmacy, 931-559-6337.
And until next week, remember to stay tuned here to Grace 107.7. And remember, at Matt Libby Insurance, we can cover you from head to toe. It doesn't have to cost you an arm and a leg.
You've been listening to Insurance Matchmaking with Matt Libby, your path to health, life, and Medicare coverage with Matt Libby Insurance.